So for the final lecture, I'm going to briefly talk about self-efficacy theory and how we can apply that during treatment, and also motivational interviewing. I'm going to go through both of these somewhat quickly, mostly because I think you'll see that most of the content, or much of the content that I'm going to talk about, is some ground that we've already covered in talking about self-determination theory. So let's start with self-efficacy theory. Self-efficacy theory was um, authored by Alfred Bandura, a Stanford psychologist, actually I think voted one of the top psychologists of the 20th century by the American Psychological Association. And uh, his self-efficacy theory says that basically for humans, our belief about our abilities to do specific things is based on some kinds of experiences that we have, our past performance, um, vicarious experience, watching other people do things, verbal persuasion, people encouraging us that we can do things, and interpretation of somatic or emotional states. For example, if I'm about to give a talk in front of a bunch of people and I'm feeling a fair amount of anxiety or fear, right? There's a, a somatic and emotional sensation I'm feeling. That feeling can influence my interpretation of how well I'm going to do when I give that talk. It might cause me to further interpret that I'm going to do poorly. Right? So what is self-efficacy? Self-efficacy is very related to competency, except that self-efficacy is beliefs that are quite task specific. So for example, if I had two rocks here in my room, a large one and a small one, I would probably have the belief that I could lift the small rock, but perhaps not believe that I could lift the large rock. Now they're both the task. They're both lifting rocks kind of task, but self-efficacy beliefs are beliefs that we have that are not only task specific but context specific. So for example, let's say I thought I could lift the heavy rock, but last night I got almost no sleep. So because of that, I'm fatigued today. And while I might normally believe I could lift that rock, because of how I'm feeling today, I might not believe that I can do it today anyways. So self-efficacy beliefs are very relevant to our clients because in my experience you'll find clients who have relatively good self-efficacy beliefs in one area of their life, in one area of their language performance, and very poor in other areas. Some people might feel fairly confident that they can hold a conversation with one of their family members fairly successfully, but have little confidence that they can do it either in front of a large group of people or strangers or under some kind of time pressure. And as I'll talk in just a little bit, how people interpret their experiences and their beliefs about their abilities will influence their motivation and how they interpret their successes and failures. So, self-efficacy influences our interpretation of our performances. What that means basically is, and I see this with my clients quite a bit actually, and that is if I have poor confidence in my ability to do a speech task, then when I fail, I will tend to interpret that failure as a confirmation of my lack of ability. On the other hand, if I feel fairly confident that I can do something and I fail, then I may interpret it in a more positive light. In other words, I may say to myself, well, I can do it. I just need to put in more effort next time. Or I can do it. I just need to slow down my speech a little bit when I get to that word that's difficult. In other words, I just need to approach the task a little bit differently. Or maybe even a patient, and I think this is often the case with my clients, they'll say, well, I know I have it within me to do it. I just need more practice before I'll get there. When people don't believe, when they have low self-efficacy, that they can do something, they tend to avoid doing it. Whereas if they have some confidence that they can do it, they will approach the goal. So for me, self-efficacy is super, super important for both the interpretation reasons and the immediate effects on motivation. We have to remember that there's a close relationship between our awareness of our abilities or our difficulties. There's quite a close relationship between deficit awareness and self-efficacy beliefs. So for example, with my TBI patients who are often have poor deficit awareness, they often will have high self-efficacy beliefs towards tasks and goals that they're quite a long way away from achieving. The risk there, of course, of having patients with distorted self-efficacy beliefs is that if we put them into a situation where they fail, there might be some degree of catastrophic kind of psychological reaction. And we really don't want people to experience those kind of negative events in our proximity when we're doing therapy with them. And that is not the way to establish trust, etc. So for me, I almost start off by thinking about looking at my patients and trying to get a sense for how aware are they of their deficits. Now, for some of my clients with aphasia, I have kind of an opposite scenario wherein the clients have very little confidence, or they underestimate their abilities. A couple weeks ago, I had the client with primary progressive aphasia, woman in her mid-70s, very fluent, and she spent a half an hour telling me in quite eloquent ways why she couldn't speak, or that she couldn't speak, and that at times she could not even get a sentence out. I've seen her for 3 months. I've never seen her not be able to. I've never seen her even hesitate to get a sentence out. And, she has word finding difficulties here and there, but to the casual observer, she could pass as normal, at least for the first 10 or 15 minutes of a conversation. Yet if you were to talk to her, it sounds like she can't hardly communicate to people. So we want people to be as accurate as possible with their awareness of their deficits, because that's going to allow them to have a more accurate and healthy self-efficacy belief. The effects of self-efficacy beliefs are wide-ranging. I won't get into them in details. These are some good studies and that show that self-efficacy beliefs do affect things like adherence to treatment recommendations, outcomes, mood, quality of life. Interesting little study here by Aben and colleagues showing that self-efficacy beliefs are more predictive of memory complaints than memory capacity. Right? In other words, if we look at who complains to their physicians about memory problems, right? And we correlated actual results on memory testing to the number of complaints, or self-efficacy self-ratings and reports to physicians. And a poor confidence is more predictive because many people think they're worse than they are. Assessing self-efficacy, I do this quite a bit. It's not hard to do. Bandura says you should use either a 0 to 10 or a 0 to 100 scale. I'll show you one of those scales in just a bit. The scales should include more than one question. Basically, you want to ask a person how confident they are they could do something in kind of the ideal setting, and then the same question under different kinds of challenges. So, for example, what I tend to do with my clients often is, let's say we're planning a home treatment program, and I might ask them, well, how confident are you that you can do this home practice, an hour a day, 4 days a week, or whatever we had agreed to? And a person would give themselves a rating. And then I'd ask them, okay, well, what do you think are some of the barriers that might keep you from doing that? Keep you from being as regular as you want to be? People will say things like, well, I still suffer from a lot of fatigue, or, if there's company over, or I've heard quite a few different excuses. And then I'll ask patients to kind of rank order them, from the one that's likely to be the most disruptive. And, we'll take a handful of those, and I'll get an idea by asking them a self-efficacy question under that challenge, and I'll show you in a bit. But the point here is that it's a nice way to understand what people believe about their abilities. And of course, once we start to learn about these barriers, well, it's quite a simple matter to engage your patient in a little dialogue about, how they can prophylactically prevent those, manage those barriers. We want to use can-do statements. How confident are you that you can successfully hold a conversation with a stranger in Starbucks, rather than will do? Because will do doesn't get at capability, it gets at people's beliefs about intention. We might need to give them kind of a concrete example of what we mean by asking people whether they believe they can do something or not. So I gave that example of me and my beliefs about lifting rocks. I've always found that kind of very, very concrete description helpful for clients. This is a self-efficacy scale, and it's covering a simple question. How confident are you that you can do your home practice? And as you can see here, it's 0 to 100, and I have a number of kind of uh, questions that start off with how confident are you? The first one being, as I said in the beginning, kind of the ideal scenario. How confident are you that you can do your home practice when everything is going well? This particular case comes from my book chapter on motivation. This individual was somebody who had these kinds of concerns. He had chronic pain, post-stroke fatigue. He lacked confidence that he could do his home practice alone without someone helping him, etc. And so you can see here that, for example, he was least confident that he could do his home practice when he was feeling fatigued, followed by when he was in physical pain. Solving these was relatively simple, and it essentially meant that he identified that time of the day when he tended not to feel quite so fatigued, which happened to be the morning, and then also he made sure to schedule his home practice for that time when he was optimally pain medicated. There is one scale that is close to a self-efficacy scale that is in our field, the Communication Confidence Rating Scale for aphasia. This is kind of a self-efficacy scale in the sense that it does measure confidence, and you can see here some sample questions. It's a very general scale. It's not really that context specific, but I do use it occasionally as a kind of measure of self-efficacy generalization or carryover, for example. Self-efficacy interventions. So there is literature out there, of course not in speech pathology land, but in related areas. And the results out there, the systematic reviews looking at self-efficacy interventions in healthcare and rehab, show some promise, but the results are mixed. Now, if we look more carefully at those studies that were done, what we find is that many of the studies did not intervene in all 4 areas of self-efficacy information. Right? In other words, remember at the first self-efficacy slide, I mentioned that our beliefs are formulated by our past experiences. In other words, if I've lifted a rock about that size in the past, I'm going to believe I can do it now. It's based off of our observations of others doing things. More specifically, it's the observation of other people who we perceive to be like us in relevant ways to the task. So I'm kind of tall and thin. If I saw somebody my size lift that big rock, then I would have confidence that I could do it. If I saw someone twice my size come and lift that rock, I might not be confident that I can do it because they're not like me in relevant ways. Then we've got verbal persuasion. Usually what we do as speech pathologists, but according to Alfred Bandura, and I think there's other evidence to support him, that's probably the weakest form of building people's confidence, right? By persuading them that they can do it. And then finally, the physiological experiences people have, their anxieties, their fatigue, those bodily experiences that cause them to change or alter their beliefs about what they can do. We can address all four of those in treatment if we want. And the self-efficacy intervention studies that did look at all four sources of self-efficacy information, if we were to extract those out, the results would be a lot stronger in terms of the effectiveness of these types of interventions. And that's what this slide is referring to. Here we see some, this is from my book chapter, some examples of clinical behaviors that we might consider that would address mastery experience. I won't go over them individually. I think they're fairly self-evident. Vicarious experiences. I will make one point about vicarious experience, because one of the places where this is clearly in play is in group therapy, right? And even before I knew about self-efficacy theory or read much of or any of the motivation science literature, when I would create an aphasia group, a dysarthria group, a laryngectomy group, I would always try and populate it with one or two individuals that I thought were good role models of recovery. And Bandura makes a point that, or others, not Bandura, others who have written about self-efficacy interventions in rehab, make a point of saying that we should do that, but we don't want super patients as models, right? In other words, we don't want models of people who made extraordinary and rare recoveries. The best models for everybody else struggling to get better, the best models are people who did struggle. The best models are people who persevered over time and were resilient and worked through different challenges and gradually got better and better and better. I don't send any of my clients to a group unless I've gone to the group first and basically vetted it for the types of role models that are there for my client. Verbal persuasion, I'll pass through that. Much of the discussion I made about feedback is relevant here. And physiological and affective experiences. There's a tiny body of literature, but it's there on biofeedback, relaxation training, mindfulness training, those type of broad treatment approaches that are stress reducing, that help people regulate their emotions and their physiology and their thoughts to some degree. So we would not be wrong. Matter of fact, I think it could be quite useful to do some of these things. The issue is, do we have time to do them? Can we bill for them? Etc. I do spend a considerable amount of time talking to my clients about their emotional experiences, their stress experiences related to their cognitive and communication performance. I do want them to understand that they maybe didn't do so well in this setting, not because of what they were ultimately capable of, but because of these other influences like anxiety, Um, and I think just heightening patients' awareness about that relationship um, is half the battle. Um, okay, let's move on to motivational interviewing. And let's start with a brief description of what motivational interviewing is. It's a collaborative conversation style for strengthening a person's own motivation and commitment to change. Miller and Rolnick, motivational interviewing really started with Miller, but Rolnick came on board shortly after Miller started this process, and together they've been the main promoters and not really researchers. Others have done the research. But the key here is it's a conversational style. So it really is a counseling technique in that it's about strengthening a person's own motivation. I think that word kind of harkens back to this idea of autonomous motivation, strengthening their own reasons for why they're there doing the work with us in therapy. Motivational interviewing historically draws from a number of influences: Bandura's self-efficacy theory, Rogers' client-centered approach, self-perception theory that talks a little bit about the fact that people are somewhat influenced by what they say out loud. In the motivational interviewing literature, because motivational interviewing didn't come out of a theory, it wasn't based on a theory, it was really based off of Miller and Rolnick's clinical experience and snippets of research here and there. But because it didn't come out of a theory of motivation or change, people have tried to find theories that seemed like that explained why motivational interviewing works. And one theory that's been put out there is the trans-theoretical approach. I'm not going to go into it. Not sure it's that helpful for us. But there have been a number of papers that have said that self-determination theory and motivational interviewing are very much in harmony. And for me, I think they're a perfect match. Self-determination theory gives you that foundation of conceptual understanding of why you're doing what you're doing motivationally with your clients. That's self-determination theory gives you that. Motivational interviewing gives you a lot more techniques, counseling techniques, and descriptions on how to use them than the self-determination theory literature, which tends to be a little bit more theory focused rather than, it's not really written by clinicians for clinicians. Motivational interviewing is a way of being with patients and having a conversation about change, which is non-judgmental and based on compassion, respect, and empathy. It's a set of learnable communication skills. I use them probably every session in one way or another with my clients. It's aimed at helping patients change specific behaviors, so it's not psychotherapy. It's not meant to address those kind of personality issues. It really is focused on helping people change behaviors. Now, the motivational interviewing, they talk a lot about changing behaviors. Motivational interviewing came out of the addiction medicine field. That's what Miller was doing when he created it. But we could take out that word change and we could say it's aimed at helping people um, engage in specific behaviors. It's patient-centered and respectful. It's very autonomy supporting. It can be brief. There is a number of studies out there showing that, a general practitioner who uses motivational interviewing in their 10 to 15 minute brief follow-up visits with clients and office consultations, that studies comparing them to physicians who don't, there's a big difference in terms of patient satisfaction and to some degree adherence to things like taking their medications on time, etc., etc. Again, as I mentioned, for me, I'm using it off and on in every session. And it is evidence-based. There's maybe 300 studies out there looking at motivational interviewing and about 20 systematic reviews. It's been around since the late 1980s. Motivational interviewing, I think, instead of having the theory, the self-determination theory is grounded in, motivational interviewing is grounded in what they call the spirit of MI, or motivational interviewing. And that spirit is that it is collaborative, right? That it is a partnership. It's not a therapist solving other people's problems or fixing them. There's a spirit of acceptance, right? We called it earlier when we were talking about satisfying the need for relatedness, we called it unconditional positive regard. And that phrase comes from Carl Rogers and that Rogerian approach. There's a spirit of evocation, in other words, a spirit of encouraging people to just tell their stories. And finally, it's characterized by a spirit of compassion. Miller and Rolnick actually added this compassion spirit element in their most recent edition of their book in 2012. Prior to that, it wasn't there, and the reason they added it was because I guess they had gotten some feedback that people like salesmen were using some of these guiding behaviors in motivational interviewing to manipulate people. So they really wanted to distance themselves from that purpose of motivational interviewing. There are also some guiding principles. The main ones here are resist the writing reflex. The writing reflex is where you try to make it right. In other words, your patient comes to you, they have complaints, they have a problem, and you, being the compassionate person that you are, you want to jump in and solve it for them. You want to give them recommendations, tell them what they should do, encourage them that they can do it, tell them they're good if they're coming in telling you how bad they are or how poor their speech is, and you're going to convince them that it's a lot better than that. We have to resist that. And in motivational interviewing, the reason why we resist it is because motivational interviewing talks about the fact that people are often quite ambiguous about these problems that they have, right? So the person who comes in who complains about how terrible their speech is, right? If we were to be inside their head, listening to the thoughts, we would often find that there are actually kind of two competing voices in there. One voice, thoughts of how bad a person's speech is. The other voice with thoughts that are more positive. I'm not that bad. I can get better with practice, etc. Kind of in the cartoons way back when I was a kid, there was, the angel on one shoulder and the devil on the other shoulder. Well, when we start to get involved with convincing people, making it right, etc. A couple things happen. One is that we're adopting the angel's voice. And when we do that, the only voice that's really left for the patient to give voice to in that situation is the devil's voice, the why I can't, right? And you can see this dynamic, right? You convince somebody that they're good, and they're left with the only thing they're left with is kind of like, well, yeah, but I can't do this. Yes, but. And we can actually inadvertently guide people to just talk about the negative things. The other reason this writing reflex doesn't help is because our patients eventually have to learn how to solve their communication and cognitive problems to some degree on their own. They have to learn to manage what for many of them is going to be a lifelong disability. And so we want them to practice that type of problem solving in front of us. And we want them to practice that so they can have confidence and the experience that they have some control over their use of strategies, their development of strategies, etc. Other principles, understanding and exploring the patient's own motivation. That would be from the self-determination theory, kind of taking their perspective, as is listening with empathy, empower the patient, encourage hope and optimism. Motivational interviewing talks about kind of counseling including 3 different styles, right? In other words, when we're in a conversation with a client, we can be directing. We can take a directing style, and here's some of the words that they think evoke that kind of directing style. It's when we're deciding, we're determining, we're leading, we're managing, we're prescribing, we're telling. Rather than in motivational interviewing, what's seen as a more productive counseling style, guiding, where we're assisting, collaborating, eliciting, encouraging, inspiring, kindling, motivating, etc. In motivational interviewing, guiding and following are used most often. Directing, sometimes you have to take a directing approach. But guiding and following is really what motivational interviewing talks about and focuses on. Now, there are some core communication skills. These are the actual techniques. And they're pretty straightforward. It's using open-ended questions, using reflective listening, affirmations, summarizing, and I stuck in informing and advising there. It's not part of the acronym. OARS stands for open-ended questions, affirmations, reflective listening, summarizing. Informing and advising, we do that. Motivational interviewing says something really simple, but I've found it to be important in small ways. And that is when we want to give people our opinions, when we want to advise them, a nice step to do is just simply to ask permission. I do it every day with my clients. Would you like me to tell you what I think about this, Mr. Smith? And allow them to, it's asking is a sign of respect. Asking is an acknowledgement of their autonomy. It's an acknowledgement that this truly is collaborative, that they're in the driver's seat to some degree. Here's an example of using open-ended questions and maybe kind of the very first session introductions. Hello, Mr. Smith. My name is Michael Beal and I'm a speech pathologist. Thank you for coming in today. I took some time earlier today to read through your doctor's notes, and I think I have an idea why he referred you to me. Before the session is over, I'll need to do some testing and ask you some specific questions. But before we do that, I'd like to get to know you. Can you tell me a little bit about yourself and how I can help you? Okay. So, in an assessment, first session, we often don't have a lot of time to do as much counseling or as much rapport building as we could, in which case it's always good to be very open about the limitations and the restrictions that we have. And I will sometimes be even more blunt. I'll be something like, we have a lot of testing to do. I've really only got about 5 or 10 minutes for us to kind of get to know each other before that testing has to be done. I wish it wasn't that way. But when people understand, then it's fine. They aren't going to form negative first judgments about what this relationship is going to be like. We can use open-ended questions to kind of start to encourage a sense that this is a collaborative event. Questions like, how would you like to begin? Besides the testing we need to do today, what else would you like to talk about? What treatment task would you like to start with today? Do you think this is helping? Why or why not? Any of those questions that are autonomy supportive, opinion seeking questions are typically open-ended, would fit under this category of MI collaborative agenda. Sometimes we do have mandated agendas. We have to do certain things, or the doctor wants the patient to do certain things. So we might have a question, something like this: I'd like to talk about how you can reduce your risk of aspiration. We can talk about how you can modify your diet, strategies you can use when eating, and therapy. Where would you like to begin? So I've kind of outlined what we have to talk about, but I'm still finding a way to use open-ended questions. In motivational interviewing, they say that, I don't remember the ratio exactly, but it's something like, 4 open-ended questions for every 1 closed-ended question. Try living up to that. It's not that easy, but that's the goal. We can also use open-ended questions to guide, again, we're doing a lot of guiding in motivational interviewing, to guide people to talk about and focus on certain things, like to talk more about their desire for therapy. Why do you want to return to therapy? That simple question. I often have patients who have been in therapy in the past, and for whatever reason, they've decided to come back in. We might want to guide them to talk more about their abilities, strengthening self-efficacy. Tell me more about the improvements you made in physical therapy. Right? Get them to talk about the reasons, some of the intrinsic reasons why they want to engage, why they want to make an improvement. What are some of the reasons why you want to improve your memory, etc. So in motivational interviewing, you really are using language in very precise ways. I didn't make up the desire, ability, reason, needs, commitment. These are things, kinds of open-ended questions that motivational interviewing does very consciously. We've looked at scales in the past. Scales are a nice way to just get the ball rolling, start getting people to talk about reasons, start to get them to talk about ability, right? I can say, how confident are you that you can, improve your speech to, this level? And they might say, a 7. And I might say, okay, that's great. Well, why a 7 and not a 6? And that little move there keeps them from focusing on the negative and guides them to talk about the positive. You could do the same thing, kind of move for an importance scale question. Another technique is reflective listening. Reflective listening is, simply stated, it's either repeating verbatim something a person just said, usually a phrase or a sentence, or modifying it slightly, but still kind of being true to the essential content of what a person said. Now, one of the first things that motivational interviewing trainers will say about reflective listening is that we have to be careful about what we do with the tone of our voice, because we can reflect back something that someone said and do it with a rising intonation that kind of turns it into a yes-no question. Right? So we could say, you don't think you have a problem? Right? That's asking for a yes-no response rather than, you don't think you have a problem. Right? Or it's quite difficult, actually. You don't think you have a problem. And then the person, the purpose of reflective listening is when done right, it tends to cause the person to continue to talk about and elaborate on that phrase that you reflected back to them. And by causing them to elaborate on a phrase that you chose to reflect back, that is how you can start to guide people to talk in the direction and what you want them to talk about. Here's an example. I'm just throwing this in where we're doing reflective listening with a rising intonation. And you can see here we just get a yes-no response. This is an aphasic person who says, doctor said, always aphasia, and I won't get much better. And you say, your doctor said you won't get much better? And they say yes. Or we could say, your doctor said you won't get much better. And then they might elaborate. He said, already 1 year depressed. We can think about those focuses of getting people to talk about their desire, talk about their ability, talk about the reasons by reflecting those things that they say that are desire related or ability related or reason related. So one thing about doing motivational interviewing is we're really paying attention to what in motivational interviewing is generally falls under the heading of what's called change talk. Change talk are these phrases that explicitly or implicitly are about their desire to change, desire to be better, their belief that they're capable of doing it, that they have the underlying ability, etc. We can also use something like what's called double-sided reflections to explore and resolve ambivalence. So this is where we're taking two things a person has said and kind of putting them together in one reflection and putting them together to highlight the ambivalence that the patient seems to be going through. The angel on the shoulder is saying one thing, the devil is saying something, and they're kind of going back and forth. Um, so one of the most powerful uses of this kind of reflection oftentimes in the middle part of a session, after you've heard a person say both positive and negative things, is to use this double-sided reflection to explore and move towards resolving some of that ambivalence. In motivational interviewing, it's thought that simply making the ambivalence obvious by pointing it out and holding your client in the anxiety producing ambivalent state for a while is sufficient to encourage or allow a person to begin to resolve that ambivalence on his or her own, to start to move towards that, attempt to do that. So that's what double-sided reflections are often how they're used. So to use the double-sided reflection skillfully, you repeat back to the client the ambivalence that you hear in their speech. And of course, it's tied together with the and. Affirmations, like verbal persuasion, like praise, we use it sparingly, and the literature on motivation suggests that praise tends to be most effective when it's given unexpectedly, right? And so unexpectedly would be, for example, I'll do it sometimes at the end of the session, walking my client out of the clinic down the hallway, past the front desk. I might say something, praising them a little bit. They're not expecting it then. We often praise people immediately after they did something we like. And that can lead people into approval seeking from us, because we really tie really concretely how they behave with whether or not we demonstrate that we think they're good or they've done good. And I think we want to get away from that contingencies kind of dynamic. Summarization is the last of the motivational interviewing techniques, and this often comes towards the end of the session, where you're really kind of doing a meta, reflective listening, deciding to bring in some important themes. Oftentimes, summarization is used when you want to change topics in your counseling, and so you can use summarization to kind of make those moves. Okay, well, that is it. This is really just a brief snapshot of motivational interviewing. There are many motivational interviewing trainers around. I've done 2 workshops. Can't speak enough about how useful they were to me. Everybody that has followed my advice and taken them, all the SLPs, just rave about the experience. So consider it for yourself someday. Again, from my perspective, the reason to buy yourself a motivational interviewing book, and get the one by Miller and Rolnick, is because once you understand self-determination theory, these techniques and how to use them become kind of obvious. It's quite a good blending.